Hello, welcome to another webinar with Kinas Medical Technologies. We're here today to discuss the use of shockwave technology in the Canidgait Treadmill Gait Analysis System for animal health and rehab. We have Dr. David Levine and Dr. Kirsten Kiki Hausler here to share their expertise with us. If you have any questions, please drop them into the Q&A chat below or send them to us directly at info@kinasmedical.com. Now let's begin.
Welcome everybody to our Shockwave webinar today. This is going to be David Levine and me, Kirsten Hausler, presenting Shockwave case selection and treatment tips for general practitioners. And we're going to have a nice clinical discussion. And if you have any questions, just let us know in the Q&A section and we'll either address them during the webinar or maybe at the end. Let's start off. So we're going to start with a speaker introduction. So that's David Levine and me, and I'll pop to the next slide and let David introduce himself.
Sure. Well, welcome everybody. Happy to be here with you, and especially happy to be here with Kiki, who I've known for 20-some years.
Yep.
And maybe even longer, but Kiki actually probably at least 15 years ago started talking to me about shockwave, and being the skeptic that I am, I was like, So, I think our journeys in shockwave, everybody's is a little bit different, but as a very skeptical person, my journey probably took longer than some people. To now where I am using shockwave 2-3 times every single day. So I am a physical therapist by training, have been at the University of Tennessee for about 30 years. I also work a little bit in infectious disease, and clinically I'm at veterinary care and specialty group, which is 2 miles from the office at the university, which is great. Work with small animal as well as some equine research, and on the human side, some of my research is focused on Ehlers-Danlos syndrome in people, and interventions and things we can do there. So I'm very happy to be here today. Happy to share the stage with the expert. Kiki, you may not remember this, but you gave me a book on shockwave.
Yes, I did.
Yeah. 15, 20 years ago that I still have somewhere. I don't know where, but
it was on shockwave and sports medicine.
It was a green book. I remember that. But anyway, yeah, any questions today? I mean, I think, the goal is demystifying shockwave a little bit. It's a very easy modality to use. I use it on both people and animals. And I think the combination of that was really beneficial for me to use it on such a wide variety of people who immediately have positive benefits to maybe help convince the skeptical side of myself.
That's true. I do remember that we started talking about shockwave, and just for my introduction, I'm CCRP, that's where we met, and I have a PhD in animal science, in behavior science, and I did quite some career in sports and worked in the physical therapy field as well. Now I'm self-employed for about 18 years now. I'm working in clinic and also in research, and I also call research, that's kind of like the horse I don't own. So it's a bit of a hobby and a passion for me. And I oftentimes in my clinical work, I would come to the point where I wouldn't exactly understand why the way or the path that we were told to use wouldn't really work in that specific animal I was trying to treat. And so I decided that I had to go back to research and find objective ways of looking at the cases that we were working on. And the other thing was that, and I think that some of you that work in the rehab field know that sometimes you are questioned if the treatments really work the way we promote them to work. And so that's why I got in contact with the University of Cambridge as well. That's where we established some of the gait analysis, the objective gait analysis work. And as you can see on the slide, there's a little icon, and that's the Gangwerkentwicklung. So I'm from Germany, and I work together with the University of Jena and Professor Fischer there. And we are doing a large puppy study. So this is kind of like my background, and I'm coming back to the shockwave side of it. We are going to look at some of the objectives of shockwave today. We're going to look at the purpose in physics, and I know physics is probably not always the easiest thing to look at, but I think it's very important. What do you say, David?
Oh, I love physics.
So yeah, we're going to look at different kinds of mechanisms in the shockwave. We're going to look at the types of shockwaves we have. So there are differences between radial and focused shockwave. Then we're going to look at some of the mechanisms behind the purpose and using the shockwave and how it biologically affects the body, and why it's so interesting to get like a non-invasive approach, and what's in the science and what we can see in our patients. Then we're going to look at the application. So how do we place the probe, depending on which machine we're working on and what we're going to work on. And then we're going to look at some one case study at least, and it's going to cover like 2 purposes where we use the shockwave on this case. And then we're going to have our Q&A session. So if you feel like sending us a question, please feel free to send it in the Q&A section. So why do we use shockwave? It's pretty new in the field, but it's getting pretty popular right now. I feel like back when I started using shockwave therapy, people were just like, oh, we're going to use another machine, so we're just going to use our hands. So our hands are very important in case of palpating and diagnosing with the fingers, but the shockwave machine has a great value in using it on our four-legged patients, and probably as well in the two-legged. So it's a non-invasive treatment. That's what I said. It has a lot of positive properties on the body. It supports the healing and helps with the inflammations. And also what I really like to treat in clinic as well is bone fractures that do not really heal the way they should. And so it promotes regeneration as well. You can promote and speed up the healing post-op. It's a conservative treatment and is sometimes of great value if you have patients that can't undergo surgery. And in cases, and that's if we go back to the book about shockwave and sports medicine, we used to only treat the chronic cases, and now we know that there's a great purpose in using it in acute cases if we make a good case selection. We can also reduce the medication in some of the cases and reduce side effects as well. And if you want to increase the exercise and make them more active, probably a bit faster than without the shockwave, that works well. And that also promotes a quality of life. So depending on their severity, or if you think about cases like heavy dogs, large dogs, and the owner is not living like on a level floor, if you can speed up some of the mobility issues you will have, that makes a huge difference for the owner and for the animal treated.
Kiki, how often is Shockwave used as a standalone versus as part of a multimodal approach in your experience? Is it ever used as the sole treatment, or do you always combine it typically with education, exercise, other things?
Well, I would put it like in a multimodal approach, because what you promote with the Shockwave is you increase the metabolism in the area of treatment, but you will also have to increase mobility, and that's through movement or other modalities. So I very, very seldomly use it as a standalone treatment. Maybe for the cases that are non-union, but then we also enhance their movements. So yeah, that's a good question. I hardly ever use it as a standalone treatment.
Yeah, and I would say the same thing. It's part of the treatment, but it's not the sole treatment almost all of the time. There's other things that go into the entire plan for that patient. So great, I'm glad we agree.
Yeah, I think it's different because where the Shockwave comes from, since it's from kidney stone removal or getting rid of the kidney stone without injuring the kidney, that's a different approach. And I mean, using it in orthopedic or neurologic cases, we want to promote moving more easily, so it wouldn't be beneficial to just shockwave it and then just let it run. So now we can jump a little bit into the physics of shockwave. It's defined as an abrupt change in pressure with a velocity higher than the speed of sound, so it's supersonic sound. And as you can see on the right side, that's what the curve looks like. So we have a pressure in the scale on the left side and time on the X scale. So a high pressure amplitude, it's compared to what we're going to see next in the radial shockwave, it's quite different if you look at the curves. It's a lot of pressure and it's a little bit of pull, so it's a push and pull on the cellular level. So you can see that low tensile wave on the bottom, and it's a short pulse duration with a high rise and a short rise up to a few hundred nanoseconds. We have different kinds of shockwave generators on the market. So there's an electromagnetic shockwave, there's the electrohydraulic shockwave, and we have a piezoelectric shockwave. And generally, the generators are different. So you can see it's electromagnetic or hydraulic or the piezoelectric, and the other thing that really changes the focal zone. So if you want to just work on a teeny tiny region, you don't need a large focus zone. But it's also beneficial if you think about the tissue that you're treating. So you're not only treating one tiny little section of it, you're probably going to go around the area as well. So that's how you want to choose the focus zone of your shockwave generator.
And based on just one thing I would add is that you can, once you've decided on the best depth of that tissue to treat, we can change where that focus zone is. And Kiki will have some slides coming up that show you different pads that allow you to change that to really focus it in on the spot.
Yes, so the focus zone, and we're going to see the slide just immediately, I think, after this slide. You want to know where your site of injury is or the tissue you want to treat, and that's how you will decide which off-stand you will use. The other side, probably a lot of you will, and I also mentioned it, kidney stones. If you look at the lithotripsy, that's where you work on the kidney stones. So that's a really high energy flux density, goes up to 3 or 4 millijoules per square millimeter. That's not the energy flux density we work with in non-unions or pain therapy or cell regeneration. So we go much lower, and it has even gone down over the last years. So when I started working with a shockwave, when I would go to the courses on the human side, we would always see people that would kind of like bite their nails and try to bear with the pain. We're not going to those heights of energy flux density, and especially not in animals, because as you can see on the top level, we also get cell regeneration, and we don't have to go to the high energy levels anymore. Or would you argue that, David?
Yeah, no, in the old days, I think Kiki makes a great point here. In the old days, some of the shockwave devices we had required sedation, both for human and animal. And today's devices are much, they've evolved a lot to where we really don't need sedation for people or animals to get effective shockwave. It's become much more comfortable. The technology's improved a lot. And it is, as she shows, I have a similar slide that compares lithotripsy to what we're using, at around 10 to 12 times less energy. Now, you can still, if you put a shockwave on something that hurts and crank it all the way up, you can still make somebody do whatever face that was, but, we are trying to keep it at a comfortable level.
Yeah, so I mean, whenever I use it in clinic, I ask the owner if they want to experience it, because a lot of times they have had, or some of them had shockwave, like maybe for bone spur or bursitis, and they're pretty, a bit concerned about their animals. Since I'm not a vet, I cannot use anesthesia, and I was looking for a device which I could use without anesthesia, and I really like the Focus Shockwave because it is not as noisy. So even the animals that are a bit concerned about noises, they don't really mind the sound of the Focus Shockwave. And if you look at the focus zones that we're looking on this slide, you can see you can go down quite effectively into the tissue, about 12 centimeters. I know it's a metric system. That's what I'm used to, so we have it here, but you can approximately see that you can reach quite some tissue down in the depth. And that's where I came from, because I started to look at the shockwave machines because I was interested in treating fascia as well, so, and trigger points that I wouldn't be able to reach with my fingers. So I was a bit limited, and then I looked at this device, and that worked well. So I tried out different devices and looked at the animals, how well they would respond, or not respond to it, to the level where I was able to treat them. You can see that they can react to it, or they will react to it, but they're not really that painful. So if you look up here, and I'll try to get my marker in, with the laser pointer, this is the skin level, and this is the penetration depth that it will go down if you don't use it with an off stand, if you have the small off stand on, or this one if you wanted to, for example, treat any kind of tendons or any swelling in the superficial area, or maybe even wounds. again, that is our focused shockwave wave. So you can see there's a bit more details about how small or how fast this pressure wave occurs. And this is again the pull. So if you work on the cellular level, you will have a push against the cell and a little pull. And within our cells, we have quite a little bit of anatomy in the cell as well. And that's how you will differentiate between which kind of shockwave you wanted to use, because there are two types of shockwaves. And actually one of them is a pressure wave, which you can see on the right side. So this would be the pressure wave, and this would be the shockwave. So the pressure wave is a pressure wave, and the focused shockwave is supersonic waves. So that would be the difference between those two physical or physics between those waves, and how fast they will occur and what kind of tissue you can treat with it. So in the radial shockwave, promotes through the tissue on a superficial area, and it will go radially around the section where you treat the animal or the person, and it does not go down into the depths that you saw, the penetration depths that you saw on the slide for the focused shockwave. Anything to add, David?
I sometimes use both focused and radial on the same patient, and I'm sure you probably do. What are your thoughts on that? Where you might treat a focus spot with the focus, but then also we have a lot of surrounding tissue that may be very tight, and I kind of use some radial to loosen that up. Is that similar to what you do?
Yeah. So I really like to use the focused shockwave around the joint areas where I want to target maybe the connective tissue even more. And I do use the radial pressure or shockwave on the myofascial pain probably. So we do, and if I treat larger areas of muscles that are painful or trigger points, superficial trigger points, I will use the radial shockwave, and I do combine them in, now pretty often, yes.
I have started using radial on all of my, and some focus, but my total knee replacement patients on the human side, not over the implant, but in the IT band and the hamstrings and a lot of the muscles that tighten up after this pretty invasive surgery. And again, being the skeptic that I am, I have been surprised how much of a game changer it's been for progressing people quicker through therapy, and because they tighten up so quickly, day to day. So that was kind of an incidental thing that I kind of, just started playing with, but I think that has made a big difference, and especially when I can't do it right over the implant, but I can hit all those other muscles that are associated. And I think that's something we sometimes get tunnel vision and just treat the spot, but we may have a lot of compensatory tightness in that limb or in the spine that we can use these on as well.
And I mean, that's a good suggestion, or using it over implants. A lot of times I get the question where they're like, well, we can't use it over the implants. Well, no, you can't use it over the implant, but what it does, and it picks up or it helps with bone density, so you can also help the implant to grow in faster or more with more strength. Have you seen those effects as well?
Yeah. So when I said we can't use it over implants, I guess we certainly can, and it has been used like over TPLO plates and CBLOs. I think if they're healing well, we don't have a lot of evidence to know what it might be doing. So I guess I don't, if all is well, I don't go right over the implant just out of safety. But in reality, likely we probably could, as long as we're not, going crazy with it. I mean, these are especially over plates and things like that.
Well,
Cementless implants where there's bony ingrowth. I don't know, to be honest. I mean, it's we're dropping $100,000 on a surgery in the human side, and there's a little bit of a fear of what we could do for at least the first 8 weeks.
yeah. So no, I mean, I spare the plate. So I would go to those parts, you can palpate and then you can see where the ridge of the plate is. And I would also always go over the bony part and never just hammer the plate. So I think that's if you know where your plates are, and if you palpate them, you can just go around as well. And there is some literature in the human field, I think, about the total hip replacement and how you can help the bone to dense up a little bit. So I think we're pretty safe. So it's sometimes I just get asked if it kind of like hammers out the plate or the implant, and we can totally make you, we'll tell you that won't happen, or it hasn't happened in my clinic, and I haven't heard about
Yeah,
that.
there's really no hammering. I mean, the machines kind of sounds like it, and I think that's where people get that idea. But I have put the, I've done radial and focus. I put it right on the tissue, perpendicular. I put a diagnostic ultrasound to see if there's even this, and there's hardly any motion. So it's interesting that, it's more of the cellular effect than some hammering, because, it sounds like it's hammering. I think that's where we get that idea. But you see very little on diagnostic ultrasound in terms of a disruption of tissue in real time.
And I think that goes back to the energy levels that we're using. So we want the cellular approach, and we don't want technically just the mechanical approach. I mean, there's more in the radial shockwave, and this is kind of like what you can see. This is the ballistic part of the radial shockwave, where you have a little bullet that shoots through that probe, and it hits the plate, and then you produce the pressure waves here. So you can also treat, and that's very commonly used, I think in the Achilles tendon as well in people, isn't it?
Absolutely, yeah.
Yeah. So, and that's oftentimes used in the equine field. So most of the equine vets are familiar with the radial shockwave, and some of them also with the focused shockwave, but that's because it's kind of superficial, and that's where you can work on the connective tissue in the tendons as well. This is a little slide that shows you the main differences between radial shockwave and focused shockwave. So the shockwave, the supersonic wave, is on the left side, and this is the radial shockwave on the right side, the pressure wave. And you can see there is quite some difference between pressure. We also have differences in pulse duration, the impact, the speed is different, the pressure gradients. So there's quite some differences, but if you pick the right shockwave for the cases you treat, you want to look at those slides as well. And you cannot really treat tissue without treating cells. So there will be a cellular response if you use the radial shockwave. But you can be more targeted. I think that's how we should put it with the focused shockwave, and that's what the name says. So you're more focused. Again, we have our waves, and I think the pull is quite interesting if you think about the extracellular matrix as well. And if you want to get some maybe even some regeneration and proliferation, migration of stem cells into the treated tissues. So that's what you want to look at as well.
And I think the one, if I add just one thing in 1 second, you know, a common description that's used, and maybe this is where the hammering might come from in the States, but people think of a radial as more of a shotgun, where it's spreading out over a big area, treating a large area, but not being super selective at any one spot, where the focused, you're saying this is exactly where I need it, and we're focusing it at that point.
Yeah, exactly. I think that's yeah, and it's a difference in noise, isn't it? I mean,
Yes, yeah. Generally, the radials are a lot louder.
Yeah. I mean,
And
the electrohydraulic is loud as well, but the electromagnetic is really just like a ticking sound. So it's not so noisy, and at least in my clinic, it doesn't matter if I treat dogs, cats, or even rabbits. They don't really mind the sound. Have you experienced that?
yeah, no, same thing. I mean, I think, you know, they might look at it for a second or two, and then they go back to laying there and relaxing. So
Yeah.
The older machines, yeah, much louder. Radial in general, I haven't used every machine. I've probably used 10 different ones, but they all are louder because it's a ballistic or pneumatic generation of the pressure wave.
Yeah.
Going back to what you said earlier, where radial maybe isn't really a true shock wave, it's a pressure wave.
Yeah. So if you look at physics, there is difference and how it spreads. And there's also a mechanism. So it's mechanobiology and mechanotransduction, how you can affect cells as well. So it's not only that we have a transporter system into the cell that is on a chemical side or currents. We also have a mechanical approach to the cell, tension and so pressure and push and pull can affect the cell metabolism. So you will get a biochemical signal response through this mechanical approach to the cells as well. So we have mechanoreceptors in the cell wall and or in the cell membrane. So it responds to mechanical input, which could be, you know, palpation or manual treatment, but you'll get a much more energy in a faster time into the cell through the shockwave. And in terms of being a therapist and being it for quite some time, you want to make sure that your hands, that they can palpate well, you don't get your arthritis into your fingers. So it's also helpful to use some machines. So let's get to the clinical considerations. We have put down that you should at least use 3 shockwave treatments, spaced at least a week apart. I oftentimes use it more often now. What's your experience?
Yeah, no, I agree. I think, you know, probably 5 is, and there's nothing magic about 5, but that may be, you know, a typical course of treatment. And then maybe a few months later, you need a tune-up and you come back in for a few treatments. But, you know, there are plenty of studies. I mean, on the human side, we have, I think, about 3,700, you know, shockwave studies at this point. And some are as few as 1. They, you know, evaluate 1 treatment, and I would say, you know, 4 to 6 is pretty common in the, you know, but we don't know the optimal.
Yeah, no, we don't know the optimal. And would you say with a week apart, that should work?
That's what we say right now. So I think, you know, in 2 years we might do another webinar, and we say now we know that it's best to do them, you know, 5 days apart, or, you know, give it 2 weeks. But, you know, again, nothing magic about a week. I think it's easy for scheduling. You know, it's enough time for the tissues to kind of calm down, good exercise to resume. and we can evaluate long-term effect, or at least, a week of, calling that long-term.
Yeah. I mean, the cases where I sometimes use a minimum or a maximum of 3 shockwave treatments are a lot of times in non-union cases. So that's where I follow a human protocol,
Right, yeah.
and
Yeah,
that
for the
works
chronic
well.
soft tissue, I mean, I often wonder, in cases of chronic pain in people with, chronic OA, if one treatment a month might be a good option, and for as long as you're benefiting. Maybe it's years,
Yeah.
but we don't have a lot of those long-term follow-ups. The only thing I'd say is that people do feel better after, when I use it on the human patients, and I think that's what convinced me more than anything to use it more on the veterinary side is, probably the first 20 people that I used Shockwave on, 19 were significantly better. And, we're calling because of that, that they wanted back in. So, then I got more into the literature like you, and became more and more convinced the more I used it.
And isn't it like they kind of ask for it? I mean, in the beginning, because it's kind of a costly treatment as well. Some were hesitant, but even that's what I see with my clinical cases with the dogs and also with the cats now, that people request this treatment because they can see a benefit for their animal, even though in the beginning there's no scar tissue or anything where you kind of like see that something happens. I think that helps as well, if they.
Well, I think it also helps to differentiate yourself from other clinics that don't have it. We see a fair number of agility dogs, and some do get a treatment once a month. And they'll bring 4 dogs in, and we treat them all, and to keep them, kind of healthy and well. And the owners, I mean, they're the ones seeking this out. I might say the dog looks great, but they're seeking this out, like you say. They want to keep them healthy.
That's true. Yeah. So placing the probe. Well, I had the slide on before with the radial shockwave. The placement of the focus shockwave probe should be perpendicular to the tissue. With the radial shockwave, you can also go into fascia treatment, and there are also some probes you can use exactly for fascia treatment with a radial shockwave. But in case of the focus shockwave, you want to stay perpendicular to the tissue. Skin preparation, you should or could clip the hair depending on probably also the owner, and if he's willing or her willing to have the dog clipped. We recommend clipping the hair. If not, you really have to wetten the site and use enough ultrasound gel to improve the shockwave penetration. So do you always clip, David?
I mean, hair is a real barrier to sound waves, whether it's ultrasound or shockwave or anything. So, I mean, there are some cases where we part the hair and we get a lot of gel in there, and I think we do okay. So it depends on the patient. No, we don't always. I mean, I think it's preferable, but you can certainly sometimes part it and get in there as well, without clipping. So.
Yeah. So I mean, we recommend, but sometimes the owner is not willing to have the dog clipped, and then we try to work around that situation. What you absolutely shouldn't do is shockwave areas over the lungs or large vessels. So because there's a cavitation effect with the shockwave, you want to make sure that there's no air-filled tissue like the lungs. You could use the radial shockwave over on the muscles, but you should not use the focus shockwave over the lungs or the area of the lungs or the rib cage. Is that what you do in the humans as well, isn't it?
You know, we treat a lot of, myofascial stuff that's in the posterior back, that's, right between the rib cage, intercostals, and things like that with a superficial focus. So I think the devil's in the details.
Yeah, that's true. I mean, we even treat some spinal issues and also in the thoracic area, but you then want to know where you point your probe to. So that's where you don't want to go over lung tissue. Some other clinical considerations, how to pick treatment intensity. As I started off with the animals and coming from the humans and watching the humans suffer so badly once they got treated, and that's some years ago, I thought that's not really a good thing if you want to hammer the tissue, get hematomas, have the body respond to the hematoma and start healing that, and not focusing on the treatment area might be an approach, but that's not what I consider the focused shockwave or the radial shockwave to do and the mechanotransduction. So we always start at the lowest energy flux density, and then we work our ways up until we get some response from the animal. If it's bearable, we'll stay there. If it's non-bearable, we'll lower down. The total energy flux density, you can go from 0.02 or 0.1 where we start up to 0.135. We sometimes, if the dog's okay or the cat's okay with it, we can even exceed those levels, but we hardly ever do that because we don't really need it. For the frequency, it's 4 to 6 hertz. I've tried to do some research on the frequencies. I couldn't really find any good references. Do you know of any, David?
No, I mean, there was kind of an urban legend going around that, frequency would affect depth of penetration, but I think that really is an urban legend. I think frequency is really a matter of comfort and how quickly you get the treatment done. I don't think it really affects anything beyond that. We had some conversations about that recently. So I think, if you have less time on your hands, maybe you're using a frequency of 8, and patient comfort. And so, no, I haven't found any, good evidence on that.
And we never use analgesia. We don't need it. And what we want and what I want is that they react to that kind of input that I give to them, that mechanical input. I mean, there's a part of where we know that the pain perception and reprogramming, especially if you go into chronic cases, occurs at the brain level. And you want them to experience some of these effects. And there's also, if you look at literature, there's an analgesic effect to the shockwave or the use of shockwaves. So they will get used to the input that they get. Is that what you experience as well in people?
Yeah, I would say, 70% feel better immediately. Some link it to substance P depletion, but I don't know that we truly know the mechanism.
Yeah, I mean, there's some in the literature, but I mean, what I can see sometimes, and that's where I go to that I assume, it's an assumption. If I can increase the energy flux density within the treatment because the animal gets more comfortable, that's where I would say it's less painful during the treatment, or maybe in the next session, you can increase to a different level throughout that session. So what are the common conditions that we treat? Tendinopathy is one, osteoarthritis is what we mentioned. fibrotic myopathy, wound healing, bone healing. Anything you would add?
I think that's a good list. I think we're still learning, and we probably need to get to the case soon, but I think a lot of us start with chronic tendon issues, you know, and OA. With OA, I would say, you know, we really have to think about the aspect of the capsule that we want to apply it to. If you're not totally sure, we can go around the whole capsule. But, you know, like for a stifle, we tend to maybe focus medial capsule. For an elbow, also that medial aspect of the capsule. But, you know, we're learning more and more.
Yeah, so there's also, and I mentioned that part of the regeneration, so focused shockwave and stem cells or even PRP is pretty interesting, and using it as a multimodal approach might be a good idea. So let's switch to the case study. So this is one of my cases. It's a German Shepherd, 5-year-old, injured her toe and was casted for quite some while. She chased a cat, and that resulted in limping. As you can see, and there was a cluster splint, and I don't have a picture of that, but that was placed on her paw, and the owner tried to keep her on a lead for short walks, but she's a very active dog. That's one of the follow-up x-rays, and you can see that it did not really heal nicely. There's still some swelling around the toe. The dog was still in a cast because of this follow-up x-ray. They had some possible options of amputation if it wouldn't heal. And there was a severe wound that I will show you just in a sec. The clinic referred this case, said either we're going to do amputation or we'll give it a go with a shockwave. So you can see this is on the calcaneus. That was due to splinting, even though the owner went into the clinic 3 times per week. That was not enough. And we have 2 issues. We have the toe, or the digit, and then we have a severe wound on the calcaneus. It is sometimes very challenging to keep those cases or those dogs that are very active somehow in the splint and not move so significantly, but in this case, didn't work out. So you can see, other than having a toe that was injured, now we have a second injury. And what we did is that we used focused shockwave, in this case, on the toe and on the wound as well. So we had the digit for the non-union area. Settings would be 750 impulses at 0.1 millijoules per square millimeter dorsal approach. And we always use the long standoff in that approach. The other thing is that we use laser therapy and the shockwave on this calcaneus region, or this large wound, and you can see nicely this is week 3. The wound is closing. We also took the splint off because the dog was walking much better. And the wound protocol was 0.05 millijoules at 1,000 impulses per treatment. And we would cover the entire region of the wound. We always cover it with some wrapping. The probe would be covered with some wrapping. And after that, the dog would only wear like a light sock, no splinting anymore. And that's what the dog looked like. So we started, go back. So that's about 4 weeks after we started treatment. That's what the case looked like. So, sorry, that's the wrong one. That's one. So you can see the severe swelling and the wound in this area has closed. The fur is growing back, and we do have, it looks a lot better. So, but how do we know? Because the owner was refusing now to go back to have an X-ray taken. How can we know that dynamics are much better now? So now we have the wound that is closed, but what about the fracture? In this case, where the owners refused to go back to have an X-ray taken, as we recommend, we decided to analyze her on the Canidgait Gait. That's our kind of dynamic diagnosis tool to use in clinic. So we would look at the paws. So this is the front left, hind left. This is the front right with the toe fracture in the beginning. So you can easily look at the paw prints, and then you will compare in a follow-up what happens. So this is where we had a wound, where the wound was closed. That's where we started with looking at dynamics. We still have some changes between the hind limbs. And so in the front, we have 73 and 75% of body weight. And in the hind limbs, you can see a little bit of offloading. If the dog was severely limping, and we would still consider that the dog would still have that fracture, not being able to use that limb, that would be more offloading. And we remeasured, and as you can see, that's pretty recent, where we remeasured the dog. You can see there's a good loading on that hind right limb now. So we do follow-ups every once in a while, probably every 3 to 6 months after we have those incidences. So this is where we have wound closing. You can still see that there's a little bit of dragging in that toe because of the incidence. And this is just recently where you can see the dog is really able to use his paws, his hind paws. We don't have much of a shift in the center of pressure anymore. And we're pretty happy with that result. We still want him to get some x-rays on the toes, and he agreed to go back and have those x-rays taken, but I can't show you them right now. This is the center of pressure on the paws and the finding. So you can see here that's a little bit of dragging as well. This is how the dog places his paw, the front paws, and that little black arrow is the way the dog places the paw. And you can see that has changed. There's no dragging anymore in the hind right paw. So I just rushed through the case because we were discussing a lot, and I don't want you to not be able to get your questions and the answer session now. So anything you want to add, David?
There was one question on the use of Shockwave with patients with intervertebral disc disease. You know, from my perspective, we don't know that much. There's a funded study by Morris Animal Foundation for lumbosacral disease and IVDD, but non-operative, that's ongoing right now. Do you see anybody doing it post-op over areas that have had intervertebral disc, you know, decompression, laminectomy?
I haven't done it on post-op cases, but I've done it on some cases, on some pain cases, and in those, a lot of Frenchies, I'd say, and some of the spinal cases we see that are chronic cases which cannot have surgery, but we haven't done it on post-op cases so far.
If you could pull the gait analysis graph back up, there was a question about that. on what represents the percentages shown in the gait analysis graphic.
On what so that's the percentage of body weight on each paw? Was that the question?
I think so. And this is at a walk, right?
This is at a walk. So we always have, I only have it here, so we always make sure that we have the dog walk at the same speed so we can compare those forces. So if you have the dog walk at, so it's a treadmill we have the dogs walk on, so that's what it looks like down here. We especially use the treadmill because that's how we can make sure that they always walk at the same speed. And the speed we choose for the follow-ups is the exact speed we would choose for the initial and the follow-up, so we can compare it exactly to each other. Because speed makes a difference. I mean, there's more force produced the faster they walk, so it would look differently in a trot, but this exactly is a walk in a dog. It's at 4.1 kilometers per hour.
It looks like we have 4 minutes. I don't see anything else. So let me ask you a question before this cuts off. What would be the top 3 diagnoses that you use Shockwave for in small animal practice?
I do use it a lot on TPLO cases where we get issues with the patella tendon. That's where we use it really frequently now. We do a lot of biceps tendon cases, so that would be the tendons. We get referred non-union cases because the word has spread for the non-union cases. And what we also see now quite often are some of the greyhound or whippet with the corn or with issues on the paw pads. That's where we use it a lot now.
For the general practitioner, if you're a general practitioner and you are thinking about Shockwave, do you think your biggest percentage would be osteoarthritis?
Yeah, I mean, the elbow is a really good spot where you can use it as well. And as you said, like if you treat the capsula and maybe even have both, so you can treat the capsula with a focused, that's a good thing. And then go around and treat the myofascial pain with a radial shockwave. Or you can also use like a focused shockwave and trigger points. That works well. Yeah.
Well, it's great to see you as always, Kiki. And I think the webinar is going to end in a minute anyway, so it seems like a perfect time to wrap up. And I wish you a great holiday weekend.
Yeah, I wish everybody a great holiday weekend. Thanks for watching, and I hope you enjoyed our webinar as much as I did, and it was great seeing you. Love that you still know about that book.
Yeah, it's, if I dig enough, I could find it. So I should have had it out. But,
so just run into clinic and get some dogs treated with a shockwave.
Yeah, I am going to run the clinic myself. So good to see you. I'm going to get some scrubs on though first.
Perfect.
All right. Bye.
Bye-bye.
Thank you for joining us today for this educational webinar with Dr. David Levine and Dr. Hausler. It was very informative and it was great to hear these case studies with these modalities. If you are interested in adding shockwave therapy or the Canidgait treadmill system to your practice, we are offering a special promotion with the mention of this webinar. Reach out to me directly at gustav@kinasmedical.com to hear this and other specials we are offering. Join us next time for another great webinar from the clinical experts that help progress the shockwave community forward. Thank you so much for taking time out of your busy day to attend this webinar, and I hope to see you on the next one. Goodbye.